Good afternoon, everybody. I hope everybody made it home safely and now is getting into a new routine and learning from home. And I hope you're all ready to get right back into it. So today we're going to be talking about Chapter 12, Psychodynamic Therapy. These videos are going to be pretty brief. So it is going to be your responsibility to continue to read the slides. I encourage you to also download the slides because I do include my own personal notes at the bottom of each slide. So I encourage you to do that. I will be using my notes at the bottom of the slide, so you will be kind of able to read along as well. Or if you prefer not to watch the videos and just read the slides, that is fine as well. I just got some requests to kind of make some brief videos to kind of help explain the comments that we're working with. So when we think about psychodynamic psychotherapy, so anytime we really talk about psycho, we're oftentimes thinking about Freud. Think about like psychoanalysis. So the original approach that Freud had regarding psychodynamic therapy was known as psychoanalysis. Since then, there have been many other terms that people are now using when we're defining psychodynamic therapy. That can include the psychoanalytic psychotherapy, neo-Freudian therapy, and psychodynamic therapy. Psychodynamic therapy is just kind of an overarching umbrella that includes all of these different terms. So when we're talking about psychodynamic therapy, we're often thinking about those unconscious types of motives somebody has. So one term that they often use is insight. So looking inside oneself and noticing something previously unseen. So trying to get to those unconscious motives to understand what the client is thinking, what they're feeling, what other mental activities the clients are currently aware of when they first start therapy. When we're talking about the unconscious, what we want to do is go through the process of making the unconscious conscious. Presumes that the unconscious part of our mind exists in the first place. So you have to believe that every person has an unconscious mind. If you don't believe that we have an unconscious controlling our behaviors, psychodynamic psychotherapy is probably not the route you're going to want to go. So first off, you need to believe in the existence of the unconscious. You have to believe that the unconscious has a lot of control over our day-to-day, minute-to-minute activities. Everything we do is being pushed and promoted by our unconscious motives. And that our unconscious process underlies all forms of psychopathology. So our unconscious is responsible for all of those psychological disorders and behaviors that people experience. So how do we access the unconscious? Well, there are many different ways that we can do that. Just to list them would be free association, Freudian slips, dreams, resistance, and then defense mechanisms. So when we're talking about free associations, this is a technique in which psychodynamic therapists simply ask the clients to say whatever comes to mind without censoring themselves at all. So if I just said, "What are you thinking of? Tell me the first thing that comes to mind." That would be an example of free association. It's kind of similar to complete the sentence that we did in class, but this is just being completely free without any prompts. That is going to be the difference between like a sentence completion and a free association. The free association is typically not going to have any types of prompts to them. Freudian slips. Psychodynamic therapists who witness a client's slip of the tongue during a session or hears a client's story of such events may be able to get a glimpse into the person's underlying intentions. So for example, let's say the person says, "I just hate Jane. Jane is a horrible person." But later they say, "I love Jane." A psychodynamic therapist might say that is a Freudian slip, that although you're saying you hate Jane, you might really like Jane. Or another example would be is that you talk about how in love you are with Tommy, but then the next time you say, "I just love Frank so much," and Frank is just supposed to be a close friend of yours. That would be an example of a Freudian slip as well. They would believe that you actually love Frank, and that is your unconscious trying to tell you that. One area that I really enjoy looking at is dreams. Freud theorized that when we sleep, our minds convert latent content, so that raw thoughts and feelings of the unconscious, to manifest content, the actual plot of the dreams where we remember it. You are going to want to know the difference between latent content and manifest content for the test. So I repeat that latent content is that raw thoughts and feelings of the unconscious, where manifest content is that actual plot in the dream. This process is called dream work and uses symbols to express wishes, which can result in the unconscious wishes appearing in very distorted or disguised forms. I actually have a whole book that is dedicated to analyzing different types of dreams, different themes. I just think that there's a lot of value in what we dream about, and whether or not it is actually our unconscious or it's just our brain trying to process all the information we take in each day, I think that there can be a lot of value in our dreams and analyzing them. Another thing that we look at when we're talking about psychodynamic psychotherapy is resistance. When clients sense that a certain unconscious thoughts and feelings are being laid bare too extensively or too quickly, we start to feel anxious. We might start to close up and not be willing to share as much information because we worry what that would reveal about ourselves. And last but not least, our defense mechanisms. And psychotherapists believe that by identifying clients' unconscious defense mechanisms and bringing them into the client's awareness, they can improve their clients' lives. And really, if we can look at our defense mechanisms and how they come out in our interpersonal relationships, there probably is a lot of value in understanding how each of us have our own defense mechanisms and how we use them in stressful situations. So free association, I kind of already touched on that. So free association is going to be just asking the client to have whatever comes to mind, where word association is going to be giving them a prompt and having them respond to that. Freudian slips, everything we say has a purpose to it and that it's not random mistake, it is actually a Freudian slip, even if we say something that we don't mean. We talked about dreams, resistance, and then defense mechanisms. So think back to like general psychology where we talked about the id, the ego, and the superego. Those are the three forces we're talking about when we're talking about the defense mechanisms. And what happens is that when our id, the id is like the little devil on your shoulder telling you to do whatever makes you happy and whatever makes you feel good. Your superego is that higher moral being. Think about the little angel saying, no, that is wrong, that is bad, we can't do that activity. And our ego is the one that mediates between the two. But when there are conflicts that can't be resolved through the id and the ego, that is when we start to get our defense mechanisms. And read through the notes that it further explains that a little bit as well. So some common defense mechanisms that we often see are going to be repression, projection, reaction formation, displacement, and sublimation. I have definitions of all of those down below in the notes, so you'll want to make sure you read through that. So Freud also believes that we go through psychosexual stages of development. If we do not have our needs met or do not develop correctly through those cycle stages of development, that is where we can often see psychological issues further in the future. So the first stage of development is known as the oral stage. That is that first year and a half of a child's life, and all of it focuses on the mouth being the area of pleasurable sensations. So think about whether a child breastfeeds or bottle feeds, or maybe they like a pacifier. If they don't properly work their way through the oral stage, eventually they can become a dependent type of person, or they'll have oral fixations. So think about those people that have to be chewing on something all the time. Maybe they're a smoker, maybe they like to chew gum, maybe they're a tobacco chewer. Freud would say that all of that is rooted back to that oral stage and that the person did not develop successfully through it and got stuck at that period. And although fixation can happen for a variety of reasons, most often it occurs when parents do either too much or too little in response to a child's needs at a certain stage of development. Next is the anal stage. And the one thing that we're going to see at this stage, maybe in a clinical setting, if the person would not work their way through it, is that need for control. So think about when you tell somebody that they're anal retentive or they're an anal person, they like things very organized, in control. That is kind of where that terminology comes from, is Freud's psychosexual stage of the anal stage. The next stage is going to be the phallic stage, which occurs between the ages of 3 to 6 years old. And this is where we see that Opidius and Electra complex. So a child's wish to have special close relationships with the parent of the opposite sex is what we're seeing when we're talking about the Opidius and Electra complex. Here, the key thing that they need to go through is feeling self-worth. Do they feel loved and do they feel confident in themselves during the stage? If not, they may be stuck at the phallic stage. So going back to those different psychosexual stages, it only covers the 3 of them here, the earliest stages. Whether or not you believe in them or not, just from a psychodynamic Freud point of view, that might be some ways that somebody's going to be suffering from psychological problems based on not being able to make their way through those stages. The next couple of stages just talks more about some of the more contemporary types of views when we're talking about psychodynamic types of therapy. Brief psychodynamic psychotherapy is very common in recent years. It is less than 24 sessions, but when we think about insurance billing, 24 sessions is probably actually a very long time. But maybe when we're looking at the old way of how Freud may have done sessions, it's probably a rather brief amount of time. The problems are mild and narrowly defined. The therapist is an active participant in the section, and it focuses on the present rather than solely on the past. So many of Freud's theories were focusing on past behaviors that may have occurred, where when we're talking about more of the contemporary forms, the focus is on the present rather than the past, especially if we're looking at like the psychosexual stages. That is all focusing on past types of experiences. So that would be more of a old way of thinking about psychodynamic therapy, where contemporary is focusing on the present. I'll let you just take a look through this. It's just a comparison of brief types of psychodynamic therapy versus the long-term psychodynamic therapy. Interpersonal therapy is another form that we can look at when we're talking about psychodynamic therapy. It was created to treat depression, but it is also used for many other types of disorders. And when I think about interpersonal therapy, I think about those types of relationships that we have with other people. Compared to even brief psychodynamic therapy sessions, typically with interpersonal therapy sessions, we're looking at 14 to 20, so quite a bit less. Yet, once again, it still has focused and limited goals, and it does have specific therapeutical guidelines that we are going to follow. So for interpersonal therapy, the assumption is that depression happens in the context of interpersonal relationships. So what we want to do when we're talking about interpersonal therapy is to really improve those relationships that can help with those depressive types of symptoms. There are 3 main stages that we look at when we're talking about interpersonal psychotherapy. So first off, the first stage, which lasts about 2 sessions in most cases, involves categorizing the client's problems into one of the 4 categories listed, such as role transitions, role disputes, interpersonal deficits, and grief. Then we move into the second stage, the intermediate sessions, and this lasts about 10 to 12 sessions depending on the person, and it emphasizes improving the client's problems as identified in the first stage. Common psychodynamic methods are used, including a focus on current emotions, explorations of transference, and resistance. Also, the immediate stage often includes an educational component in which the therapist teaches the client about depression and its symptoms. So you would teach the person, what does depression look like? What do those symptoms look like? When does your depression get worse? What are some things we could possibly do to mediate that before your depression escalates and gets worse in certain situations? The final stage, which lasts 2 to 4 sessions, involves a review of the client's accomplishments, recognition of the client's capacity to succeed over depression without the therapist's continued help in an effort to prevent relapse. So kind of coming up with a plan for the person, what to do next time they face depression. And hopefully by that point, they have worked on the client's interpersonal roles. So when we talked about interpersonal roles, we said role transitions. So maybe that would be a role transition would be now becoming a father, becoming a wife, just how your role changes in your interpersonal worlds. Or there might be role disputes. Maybe you're having arguments at home with your spouse, your loved ones, your children's. Maybe you don't have those interpersonal skills. Maybe you don't know how to build relationships, be sympathetic, empathetic. How can we help build those deficits? Or maybe you're going through grief. Maybe somebody that you loved passed away. And how do we move through that and get past those feelings of depression and build some other skills and maybe build other relationships to help support you during that time of grief? So that would be interpersonal therapy. Like I said, really focusing on those interpersonal relationships we have with one another. I'm going to slip past this one. So one of the difficult things, though, to do with psychodynamic therapy is to really gauge how well it is helping a person, especially when we're talking about things such as the unconscious. From an empirical researcher's point of view, the challenge of defining and measuring the outcome of psychodynamic therapy is that how do we measure unconsciousness? How do we measure transference, insight, and defense mechanisms? Those are all things that are going to be very difficult and challenging to measure, and therefore it's difficult to determine whether or not psychodynamic therapy is actually being an effective form of therapy or not. Not to mention, we also have the issue of allegiance effects. It influences the researcher's own bias and preferences on the outcome of their empirical studies. So really, if you want to find research that supports psychodynamic therapy, if you look hard enough, you'll be able to find research that supports psychodynamic therapy. If you want to find research that promotes bloodletting through the use of leeches, yeah, you could probably find research that supports that as well. So one thing you always have to take with a grain of salt is that effect of allegiance effects, and that really we can transform the data or our personal preferences can come out in our research types of settings. So when we talk about the allegiance effects, these can be quite powerful. When we look at comparative reviews of psychotherapy literature and comparative studies of psychotherapy, they often found a surprisingly strong relationship between the way therapies were rated and the orientation of the researcher doing the rating. So if they were practicing psychodynamic therapy, they were more likely to rate psychodynamic therapy as working well compared to maybe cognitive behavioral type of therapy. So one thing to keep in mind is just to always consider who is completing the research, where their viewpoints land, and how that impacts the effectiveness of therapy when we're looking at clinical types of studies. So I know that was very quick and a very brief, fast overview of psychodynamic therapy. If you have any questions, let me know. Please send me emails if you have any questions. If anybody would like to do office hours for tutoring sessions, send me an email. We can set up a Zoom meeting and meet kind of like this type of setting where we can meet face-to-face, and I can hopefully answer any questions you have. I will be working on a video for chapter 13 as well, humanistic therapy, which is one of my favorites. So that will be up in the next couple of days. I hope everybody's staying safe and enjoying their time at home. I know I'm enjoying my time with the girls. They're a little busy and crazy, and they'll probably make an appearance on one of my videos yet. But just stay safe out there, and if you need anything, reach out. Thanks.